Hello and welcome back, everyone, to this open session on the committee for, what is our committee named again? The Committee on the Security of America's Medical Supply Chain. And we are now moving into the session that I would describe as the sharp end of the stick, the purpose of these supply chains, the people that actually use this stuff that they deliver. So we're going to hear some perspectives from end users, and the way that we'll proceed is we're going to ask each of you to talk for 5 minutes and give us sort of an overview perspective, and then we'll move into a Q&A session. And if this morning's session is any guide, we expect that to be pretty lively and informative. So thank you all, panelists, for being here. We know you're busy people, and we appreciate it because this is how we're learning about the supply chains that we're trying to study and produce an impactful report. So with that, let's begin our introductory discussions. And SUZANNE SCHRANDT, founder and CEO of ExPPect, you are our kickoff speaker. So can I give you the floor?
Great. Thanks so much. Can you hear me okay? Great, okay. Well, good afternoon, and thanks so much for the invitation to join this discussion. It's been an incredibly informative and maybe a little sobering 2 days. My name is SUZANNE SCHRANDT, and I'm the founder and CEO of a patient engagement initiative called ExPPect. My role today is to provide the patient perspective on really all that has been discussed. Obviously, patients are not a homogeneous unit, so I can't possibly give the millions of unique perspectives that patients might have. But what I will do is provide some reactions and some ideas based on my own experience as a person with a lifelong rheumatologic disease, and also from my professional world, where I've spent a couple decades working to infuse the lived experience and the wisdom of patients into the co-creation and the co-delivery of healthcare. There was a great deal of information to react to, so I'm just going to focus on a few key issues, and I'll save my other thoughts for our discussion time. But first, I was really struck by the framing and the definition underlying the term critical as used for the list of therapeutics and countermeasures and inputs. And if I put on my lawyer hat, the orientation is similar to me to EMTALA, that these are the tools we need to be able to deal with patients in life or limb emergencies. But there's a whole second layer of patients who I would urge us to think about as sort of the pre-emergent patients. These are chronically ill patients like myself who need consistent therapies and for whom, depending on the condition, a sudden interruption in treatment causes the wheels to start coming off quite quickly. And I think Dr. Schondelmeyer mentioned this concept yesterday using insulin as an example. So if the very sort of simplified goal is to have enough of what we need to treat people in these emergency settings, it seems like an equally important goal is to try to keep as many people out of emergency settings as possible, which means keeping the chronically ill and high-risk patients successfully maintained at home. And I worry a little bit about creating a hierarchy unintentionally that's hyper-focused on one category of patients versus another. Especially, and this just came up in the last session, when we add issues of equity and health disparity and who is most likely to be on the losing end of such decisions. A second and very related issue is about multiple indications for some of the drugs on the list. This may actually be more of a question than a comment, but what does it mean to be a therapy on this list? If it is solely for emergency use, in a way that actually removes supply from the chronic care setting, then that's worrisome. And I don't know if it was coincidental or intentional that I'm a patient in the rheumatology community, but we have been particularly affected by the pandemic in this way, with the rush to use hydroxychloroquine back in the spring and the early summer. But even now, as monoclonal antibodies and other biologics that we depend on are being explored for emergency uses. So how does placement on the list manifest itself? And is there a plan for almost supplemental guidance with Plan B or Plan C or Plan D to potentially affected patient populations if our mainstay therapies run the risk of being prioritized to treat emergency conditions. It is a little bit humbling to be the only patient representative in this discussion, but I feel pretty confident that I can speak broadly that most patients have no idea that these risks or realities of shortages exist. Maybe we can look at that as an opportunity for education and awareness, but the time to inform a patient community that there has been a supply interruption is not when we run out of therapy. I think too often we look at patients narrowly as sort of passive recipients of products, but in fact, patients are tremendously resourceful. They can be very effective partners in troubleshooting. I think, life with a chronic disease is all about adaptation and sort of MacGyvering our way out of the jams we get into. Lastly, just real briefly, I want to touch on the topic of vaccines because that's come up quite a bit, specifically the emerging COVID vaccine, but the same concepts apply to any vaccine and really any therapy or device. The depth and the breadth of the expertise that has been involved in the last 3 days of the discussion really shines a light on how incredibly complicated the medical supply chain is. But I would propose we make it even a little more complicated by just being sure we are integrating the perspective and involvement of patients and patient communities through each step. And that starts way back at ideation of a new drug or a device, but it carries through all the way to the use of that drug or device by the patient. And for many products, getting it to the clinician or getting it to the clinic is not the same as getting it to the patient. And Bill Murray mentioned patient-centric approaches in his remarks earlier. I think this is the most critical piece, and I can say more about this when we get into the discussion. So thanks so much.
All right. Thank you very much, Suze, and points for getting the verb MacGyvering into your overview. All right. Next up is Christopher Newton from the UCSF Benioff Children's Hospital in Oakland, where he's the co-director of the Neuroscience Center. So, Chris, please take it away.
So, thank you very much, and thanks for including, in these discussions, the piece of the pie that includes kids, as a little bit of, and you can go to the next slide, Ben. As part of introduction, let me set this up about exactly a little bit what I do and why I'm here. So, yes, I'm an active trauma director and surgeon. I am the PI for one of 2 centers nationally that got funded by ASPR and HHS in 2019 to look specifically at pediatric disaster management on a large regional basis. So one of these centers is in the West Coast, that's mine. The other is in the Great Lakes region, including Ohio and Michigan. You put these 2 centers together, and we encompass roughly 1/4 of the pediatric population in the U.S. So as part of this effort, and this began pre-COVID, one of our missions, one piece, was looking at supply chain issues. And there's lots of folks involved in this discussion. So I want to disclose out there, I am in some ways a mouthpiece for a whole group of people that have been involved in this for kids for the past year. And of course, COVID changed a lot of our discussions. Next slide real quick. So when we began talking about this even pre-COVID, this was too overwhelming for us. And it's a really complex issue when you begin to talk about all of the factors for kids. And as the conversation went on, there's several things that we had to limit our discussion to and make assumptions to make the focus productive. So let me give you a few of them, and I'll tell you where we wound up with our discussion. Number one, the definition of a child is not exactly simple, and it's not obvious, and it's a little controversial. So we made a gross assumption under the age of 10, less than 30 kilos. This applies to specialty needs for equipment and formulary. The time frame of when you might need this list is also, it changes the discussion tremendously. Are you talking about a pediatric hospital, a community hospital, a transition place in a tent? And those different paradigms mandate different sets of equipment for kids, and you don't necessarily need the entire list for every scenario. So you have to tailor the conversation for us, we found, to specific needs. And we also had a great appreciation for work that's already been done, and we wanted to integrate that into what we were talking about. Next slide. So specifically for kids, and your panel is already doing this, we also had a great appreciation for the differences in equipment and formulary discussions. And this is particularly profound when you're talking about pediatric needs. Totally different paradigms and totally different experts of who can give you the insight of what should be on which list. Next slide. So other few kind of refining issues that were important to us as we were pulling this together. Rare versus common becomes a very difficult discussion. So there's a list of medications out there that do not impact a large number of kids in the population, but are nonetheless critical. If they don't have them, that patient population is really in trouble. On the other hand, looking at kids, you got to cover the full gamut of asthma as an example, because that is the number one use thing across the entire population that every place has to have on stock. So talking about these two paradigms, was quite important. This also plays into in equipment when you're talking about specialty equipment that is only prepared by maybe a single vendor, because it is rarely used and small. And so the supply chain, not just the what's on the list, becomes part of the conversation that becomes complex and difficult. Finally, practical items that don't wind up on the list, but nevertheless are important. And the perspective that we brought from this is lessons learned from previous events like Katrina, like Haiti. Some things that are really, really important aren't on our list and aren't on our radar. Like silly things like diapers, which if you don't have, you got a practical problem. But okay, that's not on a formulary. And how do you address that? All right, next slide, please. So you go through all these paradigms, and we look through the FDA critical list. We're, so impressed with all the work that's already gone into it. It's quite extensive. We've gone through this with several groups of experts, looking line by line. What is critical need for a child? And the theory that we came up with was having a master list that includes a lot of different things, with the concept that depending on the scenario needed, you would pull out specific things based on, are you a community hospital? Are you working in a tent? Are you the strategic national stockpile? So on and so forth. So this is an example of the types of things that we were pulling out that are quite pediatric specific. And some of them are maybe things that no one would ever think about. Like, hey, if you're going to have a compounding cookbook for a formulary, you have to have syrup. And none of those cookbook formulas work if the child won't take it by PO. So a lot of these practical things we've actually written down on a list that we're happy to share. And I'm not going to go into detail, but happy to share more questions as time goes on. Next slide. So I'm not going to go through each of the committee focus questions, but I at least wanted to really give perspective on this particular focus question that everyone is asking, and that's what makes something critical for a child. And we spent a lot of time in our group over the past year challenged with this. And the bottom line is, life-threatening urgency becomes at the top of the list, of course. Lack of alternatives becomes a very important consideration. For kids in particular, there's a lot of things on the formulary, there's a lot of things on your equipment list that could be used with your adult equipment and size. It can be MacGyvered, I'll use the verb. It can be MacGyvered for a kid for a lot of different things, but not for all. And the important consideration for kids is recognizing exactly which are those few things on the list that cannot be substituted and that must be had within either a short time period, 1 hour, or a transitional time period, 2 to 3 days. And those are the parameters that we really use to scrutinize the list. And I know time is short, so I don't want to get into too much, and I'll take questions as we talk to the whole group.
Okay, thank you, Chris. I'm sure we're going to have questions for you. All right, next up, we have Ryan MAVES, who is a faculty physician at the Naval Medical Center in San Diego. Ryan, the floor is yours.
Thank you very much. Can you hear me okay? All right, wonderful. So my name is Ryan MAVES. I'm a Navy captain. I'm an infectious disease and critical care physician in San Diego, an adult critical care physician. This is speaking from kind of the more classic and I think high visibility area of critical care limitations in adults. So my perspective will be not as broad as my first colleague who was speaking, nor as focused on pediatrics as my prior colleague, is Dr. Newton. Next, please. Next, kind of standard disclaimer, I am an active duty naval officer. These are my opinions, not the opinions of the Navy, Department of Defense, or the government. Next, please. So, when we look at the intensive care unit as a microcosm of the hospital, one of the concerns we have is that the loss of ICU capability is a rate limiting step for most major hospital functions. That is, if the ICU is overwhelmed and non-functional, then our ability to manage severe infections, including COVID, is limited, and with resulting increase in mortality. Our ability to manage major trauma is limited. Our ability to handle common things like major surgical procedures or myocardial infarctions all are limited. And so there has been a great deal of attention in public health system to maintaining the smooth operations of critical care functions within the hospital, both for COVID and for the care of non-COVID conditions, which continue to be problems. Next, please. So when we look at the features of hospital surge, the three traditional features of that, stuff, staff, and space. And we're talking today about stuff, and so we'll focus on stuff. This is a graphic made by my friend and colleague, Dr. Michael Christian, who's presently working in the UK, just indicating that as we reach times of mass critical care, as we reach times of considerations of crisis standards of care, figuring out how we as a health system balance the imbalance between supply and demand, where we can affect supply of things like staff, stuff, and space through substitutions, through repurposing of equipment, through repurposing of space to try to minimize the effects of increased demand. But obviously we are somewhat limited in that. And I think as the pandemic has continued, we have learned that there are new weaknesses in this system that we didn't fully anticipate, especially now as we are in, to paraphrase my friend Dr. Jeff Dichter, a chronic contingency, where unlike a hurricane or an earthquake, which is a time-limited event, we find ourselves in an ongoing need to surge, desurge, resurge. Next, please. So this is a graphic by Dr. John Hick and colleagues from the 2014 CHEST consensus statement on surge principles. And this just indicates how, as we move through phases of a public health crisis affecting, and again, I'm a critical care doctor and I focus on the ICU, but recognizing that this concept is broader than just that. From conventional surge, where perhaps a 20% increase in our hospital capacity can be anticipated, to contingency conditions where we've doubled our capacity, up until crisis, where it's difficult to maintain a routine standard of care, and we have to refer to as crisis standards of care, which is still a form of a standard of care, but nonetheless not able to provide the level of care to which we are accustomed. Next, please. So, in the context of this, and thank you so much for the opportunity to participate in this session. I've learned a lot and also gotten to see some old friends and colleagues speak with whom I haven't had the pleasure of speaking recently. Thinking about this as the kind of the end user, as a practicing intensivist and practicing ID doctor, the stuff shortages we've seen in our surge responses are things that I think will be very familiar to the listeners and to the speakers in this session. Ventilators obviously attracted a great deal of attention. Interestingly, our shortages were not just in ventilators, though. They're in the consumables associated with ventilators. So the tubing that we have to change out between patients and periodically with the same patient. We'll take a look at some of the data on the Defense Production Act ventilators that were produced several months ago. 200,000 ventilators, or up to 200,000 ventilators produced that. Unfortunately, only 60,000 of those were what I would consider a true full-featured ventilator to support the high levels of respiratory support that patients with severe COVID-associated respiratory failure require, right? And we can talk about a little bit about why that's relevant here. Machines for continuous renal replacement therapy, for hemodialysis, were noted as an item that was very short at the first surges in New York City in March and April. Personal protective equipment has received a great deal of attention, all very much deserved, but I won't repeat that. And then key medications for the care of patients in the hospital, particularly in the intensive care unit. So antimicrobial drugs, sedatives, analgesics, and the agents we use for neuromuscular blockade, or for paralysis, which is an adjunct to the care of patients with severe respiratory failure, particularly with COVID. Next, please. So this is a graph from a manuscript which has been accepted to CHEST by Dr. Rich Branson and colleagues, which just looks at the types of ventilators that we've recently put into the Strategic National Stockpile. On the left are what we consider kind of classic full-feature ventilators that can provide the full spectrum of advanced respiratory support. And then a number of these new ones, which is actually a majority of the SNS ventilators. Most of these are not sufficient for the care of patients with COVID. That doesn't mean they have no value. There are a number of patients who require mechanical ventilators who are not as sick and can get by with a less full-featured device. There are a number of patients who require mechanical ventilators who have normal lungs and are intubated and on the vent for other reasons, such as neurologic injury or following an abdominal surgery, for example. Those ventilators could free up a full-featured ventilator to care for another patient. But again, it indicates there were some unanticipated consequences to a mass production of a highly specialized medical device by a number of companies who, God bless them for getting involved, but were new to the industry. Next, please. Of course, the challenge we're facing now, this is from the New York Times on the about 22nd of November. We've got lots of ventilators, but there aren't enough of us. There aren't enough ICU-trained nurses. There aren't enough ICU-trained respiratory therapists, and there aren't enough ICU-trained physicians to manage these patients. And so in addition to surges of stuff in space, we're finding out ways to surge staff. And a lot of that involves cross-training clinicians who have some experience in acute care medicine to support the specialized care of critically ill patients under some sort of critical care supervision. It's beyond the scope of this discussion, but just pointing out that that all the stuff and all the space in the world doesn't help you if you don't have people to do the work. Next, please. So looking at the FDA essential medicines list, and I think by and large, as an end user, I think it's a generally pretty sound list. There are some peculiarities in the list that I would just bring up to this distinguished panel. One is that the listing of a single antiretroviral drug is of relatively little clinical utility. There's some specific things I would consider for the committee, such as use of isavuconazole instead of voriconazole. Uncertain why there's 4 different neuromuscular blockade agents and 3 fluoroquinolones. The absence of prednisone, a workhorse drug for a wide variety of people, including our friends and patients and neighbors in the rheumatology community, for example. And then inhaled zanamivir, a drug that I have never once prescribed in my 21 years of the practice of medicine as an infectious disease doctor. Next, please. But so what is our bottom line? So with all of this, going over that list is interesting, but the important part is this: things are rarely critical. Stuff is not critical. For example, if I am out of cisatracurium as a neuromuscular blockade agent, which is a very common problem for us nowadays, I can use rocuronium or vecuronium or a different drug to achieve the same thing. If I'm low on fentanyl, I can use hydromorphone. Capabilities are what's critical. My ability to provide analgesia, my ability to provide neuromuscular blockade. Things are necessary but insufficient. And as this panel moves forward, what I would recommend is that we focus less on stuff and more on the end state, on the capabilities that we're trying to preserve. Products are useful, but they are means to an ends, nothing more. A transport vent doesn't replace a Puritan Bennett 980, which is a very standard full-feature ventilator, and that Puritan Bennett 980 is useless without an expert to operate it. That's all I got. Thank you so much for this opportunity. I look forward to further discussion.
Thank you, Ryan. That was excellent. All right, next up we have Sally Watkins, who's Executive Director of the Washington State Nurses Association. Sally, floor is yours.
Thank you. Thank you so much for this opportunity. A couple of things that I wanted to highlight. probably starting first of all, that the primary focus for those that are delivering direct care is that they are able to provide quality patient care and move beyond just the issue of providing safe patient care. They're in a position, nurses and other frontline healthcare workers are in a position where they're relying on others to provide the needed supplies and equipment. And that may be medications as well. And it sounds like that would be simple, but obviously there are a lot of challenges that can impact that supply chain itself, and other factors can influence either the critical nature or the availability of that supply chain. And so I wanted to highlight some of those challenges. Some can be in the way that an individual care provider has been trained. They've been trained to practice in one way, but without the available product, supply, medications, et cetera, they're not able to practice the way they're trained. And so I think this whole pandemic has been an example where we've had situations where really based on the lack of available products or supplies, we've created situations where there's really periods of moral distress. Caregivers getting frustrated that they're not able to do what they're able to, what they were trained to do. And obviously that leads to their own potential frustration with the profession. And in some situations, their frustration so great that they actually want to leave the profession. The other thing is that we have challenges even from our regulatory agencies. One of the things we've seen is not all of them are aligned. Some of them set forth standards that can't be followed in accordance with another regulatory agency. Those too can drive the need for the critical nature of certain products and supplies. The other, another challenge, a third challenge, can be the incentives. And sometimes, obviously, those can be waived or emergency situations. But if you look at the incentives around, and I'm just going to pick on the electronic medical record, are those incentives that were established aligned with what really impacts the outcomes for the patients? So that can be another challenge that's presented to the healthcare worker on the front line. I also want to acknowledge Suza's mention of prevention, because I kind of noticed the same thing, especially looking at the drug list, that we're not identifying medications that can prevent certain situations from arising that then couldn't necessarily create an emergency. So I think making sure that from that patient perspective, the critical issues have some component of prevention, whether it's related to chronic disease or some other issue that might be important. And that sort of gets into the issue of different care settings. We tend to focus in a hospital-centric fashion in healthcare, and yet we know that care is provided in a multitude of different settings. So what's critical in the hospital could be very different. It'd still be critical, but in a home care situation, it's a different type of product or a different type of supply or a different type of medication. But keeping that patient in the home prevents them from needing to move into a hospital bed situation, especially when we're seeing, critical care beds be as tight as they are. So I think that's another element that needs to be attended to, is looking at the different practice settings where care is provided. And then lastly, the most important piece, I think, is the transparency in communication that's necessary. Our frontline healthcare workers are depending upon the leadership teams to be able to be honest and transparent in terms of what's available to them, what the limitations might be, and making sure that there's an opportunity to build trust. Their healthcare workers on the front line are looking to leadership teams to protect their back and make sure they have what they need in order to provide care. And in that, there should be an environment, a culture of safety where people can articulate where they have concerns, ask questions, where they can report problems, and feel like they're not going to be retaliated against or disciplined for speaking up. And oftentimes it's using some of the systems that are in place already as a forum to keep those communication lines open, such as the utilization of safety committees, making sure we've got the right representation there so that, again, those voices can be heard. And I know in my own practice, you don't know what you don't know. So if you don't ask, open it up for conversation, you don't know where there may be issues that need some attention and need to be addressed. So that's it for right now. Thank you.
Thank you, Sally. Okay, our next speaker is Michael GANIO. Michael, am I pronouncing your last name properly?
Yep.
Okay, thank you. Michael is the Director of Pharmacy Practice and Quality at the American Society of Hospital Pharmacists. Michael, the floor is yours.
Thank you. And on behalf of our 55,000 members, who include pharmacists, student pharmacists, and pharmacy technicians, I thank the study committee for the invitation to share our perspective on the security of America's medical product supply chain. ASHP represents pharmacists who serve as patient care providers in acute and ambulatory settings, and our entire profession is all too familiar with the concerns over drug shortages and drug quality. Through a partnership with the University of Utah Drug Information Service, ASHP maintains a database of drugs currently in short supply. We also provide resources, guidelines, and tools to help clinicians mitigate the impact of shortages to ensure our patients receive optimal treatment. And to throw back to Suze's MacGyvering comment, I think pharmacists have become all too familiar with doing everything and anything we can do to make sure our patients get the prescribed drug, whether it's preparing from different vial sizes or finding alternative sources. And then, of course, in many cases, we're also asking other healthcare professionals to MacGyver, including prescribers who are trying to find alternatives and convert doses, and our nurses who may have to stand at the bedside to push a drug through a syringe because we don't have the bags of saline. So we're all doing everything we can. Although we're acutely aware of our drug supply chain vulnerabilities due to COVID-19 pandemic, the concept of these threats to our nation's drug supply is not new. ASHP, along with other stakeholder organizations like the American Hospital Association, United States Pharmacopoeia, American Medical Association, and others, has hosted several roundtables and summits over the past decade to discuss the topic. In 2018 specifically, we convened a summit on shortages as a matter of national security in response to the effects of Hurricane Maria. You'll all likely recall the devastation from that storm and the resulting shortage of small volume saline bags. And we use those bags to administer a variety of drug products to patients, everything from antibiotics to chemotherapy to electrolytes. That summit back in 2018 explored some of the risks and vulnerabilities to our supply chain and actually foresaw some of the disruptions we've experienced currently during the COVID-19 pandemic. Many of the recommendations from those summits became law in the CARES Act that was passed this past spring. This past summer, we convened a summit on safe, high-quality medications as a matter of national security, again with co-conveners the American Medical Association and United States Pharmacopoeia and American Hospital Association. The findings of that summit were just published in our journal this week, online ahead of print. So you can find that at the American Journal of Health System Pharmacy. The document contains possible solutions that are based on our current experiences with the COVID-19 pandemic. And the reality is that our drug supply is threatened not just because of geographical consolidation, but also because of quality concerns, as my colleague Stephen Schondelmeyer mentioned yesterday, with NDMA and other contaminants in our drug supplies. Some of the recommendations from both of those summits include the development of an essential medicines list. But I do want to be clear on two things. I agree with Suze with the patient perspective, especially on chronic therapy. Every drug is essential to the patient taking the medication. Of course, there are nuances here with polypharmacy and overprescribing, but in general, every patient's going to look at their medicine cabinet, the drugs they're taking, and think they're essential. The second thought that I want to start off with, before I get into my thoughts on the essential medications, if we solve these underlying problems, an essential medicines list would not be necessary. So I think we should keep a focus on global overall solutions instead of focusing on just a select few medications. First consideration when developing a list like this is, what is the purpose? The list contents may change based on the intent. Is this for incentivizing domestic manufacturing? Is this for stockpiling and creating a buffer inventory? If so, are we also stockpiling key starting materials, or are we stockpiling just API, the active pharmaceutical ingredient, or are we stockpiling finished dosage forms? There was a comment yesterday that patients can't take API. So therefore, manufacturing capacity, or the ability to use the API to manufacture finished dosage forms, must also be considered. The risk really depends on diversity of sources of materials and the complexity or difficulty in manufacturing that finished dosage form. So stockpiling these is only beneficial if we have the ability to increase capacity rapidly And some of the solutions on scaling up manufacturing capacity rapidly are these advanced technologies that are being promoted and hopefully incentivized in the near future. So now for the frontline perspective and exploring what makes a drug essential. You've heard perspectives on thinking of immediate need during emergency. So a mass trauma event, a natural disaster, or chemical and biological countermeasures. However, again, Stephen Schonelmeyer mentioned we may need multiple lists. So as far as a frontline clinician perspective on what makes a drug essential, we have emergency treatments, again, the obvious, the countermeasures, the advanced cardiac life support resuscitation meds, supportive care during ICU stays. But we also have life-saving treatments, so curative chemotherapy agents. You've heard us talk about vincristine. You heard earlier referral to BCG, a drug that's been in short supply, that's used for bladder cancer. What about medications required for organ and bone marrow transplant recipients? Another one, to refer back to just a couple of presenters here, what if you can't perform routine functions without the meds? So the ability to deliver critical care or deliver other medications. I alluded to saline. We heard a reference to syrup that can be used for compounding drugs. Now I can compound that syrup. There's actually a USP monograph for that, and Mary Poppins had a whole song about a spoonful of sugar. But anytime we have to compound these, we increase risk. There's an increase in risk for contamination. There's an increase in risk for error. Other essential meds supporting life-saving procedures. So mechanical ventilation was also referred to, but what about dialysis? What about necessary surgeries? What about contrast agents? I know that FDA did not include those, but you can't stent a clotted blood vessel without contrast media. So there are other considerations beyond just what makes a drug essential, beyond just countermeasures and emergency care. And then, of course, there's quality of life concerns. So a drug that supports a life-saving treatment like a chemotherapy regimen, you may need a drug like filgrastim to make sure your body's immune system can fight off infection. One last point that I'd like to make, package sizes and dosage forms are also important. As experienced by New York City hospitals during the COVID-19 pandemic, pulling small vials of drug, that would be 2 mLs of a fentanyl vial, for example, having to draw up either 10 of those or 25 of those is very impractical when you're trying to treat hundreds of patients. So vial sizes and package sizes are a very important part. Thank you for the opportunity to share our perspectives, and I look forward to the panel discussion.
Okay. Thanks very much, Michael. Are the reports of the summits that you mentioned there publicly available? Can we get access to those?
They are publicly available. I have sent them in, but I can make sure they're sent in again.
Okay. If our staff have them, I'm sure they'll make them available to us. Perfect. Thanks so much. Okay. To bring us home, we have Mike Schiller, who is the Senior Director for the Association for Healthcare Resource and Materials Management. Mike, you're on.
Great. Thank you so much. Good afternoon, everyone. It's a privilege to be here with you today. As mentioned, my name is Mike Schiller, and I'm the Senior Director of Supply Chain for the American Hospital Association and its professional membership group, the Association for Healthcare Resource and Materials Management. I'll be bringing the voice of the healthcare supply chain professional to the conversation, and my comments will be more strategic and broadly focused in nature. COVID-19 was the perfect storm and really exposed the fragile nature of the healthcare supply chain. Early in the pandemic, key supply chain channels in globally concentrated locations closed, lead to a decrease in production and exports of PPE, drugs, and other essential supplies, while at the same time, there was a global increase in demand for these very same products. This led many hospitals and health systems to rethink and to transform their supply chain models, from exploring and expanding partnerships with peers, traditional and non-traditional manufacturers, community-based businesses, establishing redundancy to lower or eliminate risk, leveraging digital technologies to better understand product utilization and anticipate needs, and updating supply chain strategies. These strategies include moving away from a singular focus on product pricing to more of an evidence-based approach that improves patient quality and patient outcomes, while at the same time lowering the total cost of care. Principles of ARM's cost, quality, and outcomes movement. Contracting strategies that include the appropriate evaluation and use of multi-source contracts and a diversified vendor and manufacturer portfolio. We must look upstream in the supply chain to ensure diversification exists, not only at the vendor level, but that there is diversification in the manufacturers that our vendors are sourcing from. A reevaluation of the just-in-time and lean inventory management methodologies, which create a very efficient supply chain in times of calm, but severely restricts our ability to flex in times of increased demand. We need to reassess operational and surge inventories as two separate inventories, or should they be viewed singularly as a singular managed inventory, one that extends upstream to both the distributor and manufacturing levels and comprises the entire healthcare supply chain continuum. By increasing the amount of on-hand inventory across this continuum, we improve our ability to flex in times of increased demand. We need to explore the creation of clinically acceptable substitutes at an industry level rather than at an individual healthcare organization or a value analysis committee level. This would improve and strengthen our ability to adapt and ensure uninterrupted or consistent product availability in times of increased demand. And what is the most efficient and effective approach to augmenting the strategic national stockpile? Is it through state-mandated days of inventory on hand? Is it through regional coalitions? Or should each hospital build their own surge inventories? Lastly, in reviewing the FDA list of essential medicines, medical countermeasures, and critical inputs, I'd like to commend the FDA's efforts in establishing this list. And while a list can be compiled and products can be ranked in isolation, operationally, if any one of those items is delayed, is out of stock, is recalled, care as intended does not occur. In the end, the lessons learned from this pandemic must be hardwired and incorporated into the fabric of our healthcare supply chain, from manufacturing and distribution processes to clinical and operational practices, as we rebuild and reimagine a more resilient supply chain in times of crisis and beyond. Thank you.
Outstanding. Thank you, Mike. And okay, I invite all of our panelists to come back up on stage by turning on their cameras, as well as our committee members, so that they can all see who's asking questions. So we have about 45 minutes now to engage in a discussion with you. So let me just start by saying thank you so much for being here and for all your work on the front lines during this crisis. You are doing God's work here. If I can start off with a question, to use Suze's term, there sounds like there's a whole lot of MacGyvering going on at the end of this supply chain, where you're working out solutions. The question I have for you is, how does this information find its way back up the supply chain? So as Ryan put it, you don't necessarily need a drug, but you need a capability, which means that depending on what you can substitute for what resilience really is kind of a complicated calculation that you know how to make in your particular environment. It's not at all clear that the decision makers or the nexus of decision makers within the supply chain understand that. And so how can we get the specialized information that all of you articulated into the hands of the people that are making the decisions that will make these supply chains more secure and more resilient for the next crisis? Any thoughts, any of you on that?
I'll take a stab at it and then let my colleagues chime in. I think that's probably the biggest hurdle that we need to clear. We need to develop visibility and transparency in our supply chain. We need to take this institutional knowledge that everybody is building And we need to figure out, how do we hardwire that? How do we take what we need to learn from this pandemic and incorporate that into our operational processes? And what are some of the MacGyvering techniques that we use during this pandemic that really don't need to be carried forward? So it's winnowing those factors. And then I think we really need to be bringing together the appropriate stakeholders to really vet this out. And some of those stakeholders are going to be your GPOs. They're going to be your manufacturers. They're going to be your providers. They're going to be some of the regulatory agencies, CMS, ONC, when we look at interoperability between health IT systems, HHS, FEMA from a preparedness perspective. And so I think that we need to bring these voices around the table, because let's face it, this is not our first pandemic. We've had H1N1, we've had Ebola, we've had avian flu. And as a healthcare field, we know what we need to do. I think we struggle sometimes with really taking that next step and hardwiring those lessons learned. So my biggest question, and what keeps me up at night, is what is going to be different this time around so that we do hardwire those lessons learned, that institutional knowledge that we've all gained over the last 9 months.
I would add, oh, sorry, go ahead. Go ahead, Sally.
I just was going to reemphasize the transparency piece. I think that is so important in keeping the communication flowing. I think the other component, though, and we've kind of learned this through this whole pandemic as well, is we have these smaller agencies, organizations, care provider groups, et cetera, who need a forum. And so through, I think, supporting public-private partnerships, that sort of thing, that can provide that forum so you can hear from some of these other smaller groups who don't really have, they're not part of a large health system. It might be a skilled nursing facility. It could be a home care agency. Actually, it could be the jail system, looking at implications for communicating within the public health jurisdictions. So I think that's another component of this, is making sure that there are communication forums established and vehicles so that they can articulate where it is there are needs. Thanks.
I would echo what Sally just said. I think there's two parts, and specific to the patient community, I think often we aren't looked to as a resource. We're looked to as not the problem, but you know what I mean. We are the people that need the treatment. We're not looked to as a resource. So that's one barrier to overcome, that we actually need to be brought in as part of the solution generation. The challenge, so the second half of my answer is, typically in other parts of healthcare and R&D, when you want to partner with patients, you go to a patient advocacy organization. If you're working on development of a cancer therapy, you work with cancer patient advocacy organizations. There is not an organization of patients worried about the pandemic. That doesn't exist. So what do you use as proxies? Well, you can go to existing patient advocacy organizations. Most of us in the chronic disease world are quite concerned about our risk and what's happening in our community. You can also go to proxy community organizations, go to communities of worship, go to your area agencies on aging, go to places where people are already gathered and try to get data from them about what has worked, hasn't worked, what their needs are. Ideally, we aren't adapting at the tail end of the supply chain because we've gotten it right at the start. And I think if we can build more integration of the patient perspective in at the front end of the supply chain, thinking all the way through to what it looks like to get therapy in the bodies of patients, that will go a long way. But the first step is we have to ask patients. We have to actually look at them as a resource of information.
Okay, thanks.
If I can add one perspective, Wally, I think you asked such a profound question, and it's I will acknowledge the amount of and magnitude of MacGyvering that happens on the front lines is tremendous and maybe quite underappreciated. And this includes supply chain MacGyvering. So in our own pediatric system, when one pediatric hospital needs something and they can't get it from their supply chain, they call the hospital in the next state. And there is a system of managers talking to each other and figuring it out. But when you ask the question, how does that, that cookbook, that sharing, those gaps get communicated to a high level, the end user says, well, who do I report it to? I don't know. Where's the central forum and agency? Who wants to know? We're happy to share. We share amongst ourselves all the time.
Yeah,
I hear you. Ryan, go ahead.
Yeah, no, in San Diego County and actually up in the Northwest, there's a very good model for this as well. It's very pandemic specific, but when we first received our first allocations of remdesivir earlier in the pandemic, all of the health systems in San Diego set up a regularly meeting committee from, those of us in DOD, the VA, and the university, and the other private systems in town, where we dealt with this stuff as a group and continue to do so, where we review who's got beds, we review who has medications and such. And that those lines of communication on a regional level have been very useful. Now, the communication then from our regional kind of San Diego County led group up to the state is perhaps a next step that could be done. But, so much of this has to be created locally, and the reporting is the internal discussions within our healthcare community here in San Diego County have been very fruitful. And to the extent that kind of work, and again, the Pacific Northwest did something very similar at the beginning of their surge, is a useful model. One of the challenges to this particular disaster compared with other disasters, again, is that it is generalized. Earlier in the pandemic, where you have pockets, regional pockets like the Northwest, like the greater New York area, it was easier to reach out from outside of the region to find areas with shortages. Right now, if you look at the maps of the COVID pandemic, the whole country is glowing bright red. That makes it much more difficult, and that is probably the point where these regional teams remain useful, but the absence of a centralized clearinghouse is useful. I would say on an institutional level, you said, how do we pass up information about, our shortages to leadership? And I think that's going to vary widely from institution to institution. But I think one thing that very high functioning health systems do is their administrators and their leadership work in the trenches, right? And I would say as a cultural thing, I'll briefly speak as an analogy as a naval officer. The captain of an aircraft carrier has to fly off the boat, right? He or she has to go and periodically, fly off of his or her ship to find out what is working, what is not. And as a cultural shift, as healthcare gets more fragmented, clinically trained executives spending some time in the trenches, I think, makes a difference towards addressing some of these supply chain issues. I realize that's somewhat beyond the scope of this discussion, but that is one cultural change that I think we need to look at as a healthcare community, is once you move into the C-suite, you occasionally come out of the C-suite. Over.
Terrific point. Craig, you had a question or?
Thanks, Wally. This whole discussion is, to me, the essence of, part of what we have to come out of COVID with, and that is a stronger sense of communitarian value and the working together collaborative process. Our existing institutions aren't necessarily structured well to manage that. So there are things that we're going to have to think about. So, and I'll go to Mike's question or offering of, can we consider an approach to substitutions and standardizing that process? Where's the institutional way to do that is one question. But I'm thinking about the implications. I mean, Sally was talking about trained staff, but not trained to deal with the substitutions that they were going to have to deal with. So that your notion of identifying these substitutions in a more generalized way that people understand then allows for cross-training in an anticipatory way, so that people aren't put up against the wall in a time of crisis going, holy moly, I don't know how to do this. and I'm concerned that I'm going to threaten my patient's well-being, and I can't do that. So I think that the end game, for the folks, I mean, we wanted this discussion to focus on what is the situation on the ground? How do we understand this supply chain out at the end, the people who actually have to live with the outcome of a supply chain, good or bad? And so you all have been extremely helpful in sort of exposing that you need to think about how do we build collaboratives more effectively, and how do we take into account that localities have innovation that can be shared. When I was sitting in the assistant secretary chair, I spent a lot of time with the state health directors out in the field, because how else would I know what their issues were, right? So how do we move the institutions to take into account that a lot of change is going on at the ground level, both culturally, but also very, very much in the professional technical realm? And how do we capture that and build off it is an important feature. And I think you've all sort of said the same sort of thing about it. And I appreciate that. Thanks very much.
Thanks, Craig. Okay, Masheed, did you have a question?
Sure. So this is for Suze. Thank you so much for your comments. Before my question, I want to kind of start by saying that as a clinician and as a researcher, I very much believe in both at the bedside and in research, engaging patients and caregivers in decision-making and also informing policy as it relates to research. Having said that, I'm curious to hear from you, practically speaking, how do we ensure that that voice isn't lost? So we know that organizations like PCORI have done a very good job of engaging and incorporating that perspective into the research. But what I haven't seen as much as that link to policymaking is actually when the rubber meets the road, and we really need those voices heard. And if you can speak to that in the example of the hydroxychloroquine that you brought up, and maybe how could that have looked more differently months ago when we faced that crisis with something that was needed for so many patients with rheumatological diseases, and how maybe it could have been handled differently, maybe in the context of that example?
Yeah, so I really appreciate your question. I actually spent time at PCORI helping build their patient engagement strategy. So you're singing my song. I agree, this is incredibly challenging. And as I mentioned a minute ago, one of the biggest challenges with sort of this particular topic is there's not a ready-made apparatus of gathered patients who know to be focused on the issue of the pandemic at large or medication shortages, supply chain issues. So it's a little more complicated than where we see patient engagement fit in other facets of healthcare and research. But that doesn't mean we shouldn't do it. I think using the hydroxychloroquine example, you did see some leadership from patient advocacy organizations. The Arthritis Foundation tried to be very proactive in educating their population. Here's what's happening. I think it's still on their website. They have a stepwise list of what to do if you are concerned about a shortage or if you're experiencing a shortage. That's much more of a back-end solution. What I would really like to see is much more front-end planning. And I think it's as simple as involving patients and patient representatives in meetings like this. So you've accomplished that. I'm here. Maybe have a couple more of us from a diversity of backgrounds and disease experiences, and just constantly asking the question, where is the patient perspective? And if it's not in the room, then you have to find a way to get it in the room. I don't mean to say that simplistically, but that really is the answer. Just always asking where that patient perspective is. And I'm happy to help brainstorm and think of ways to do that, and think of the organizations and the people to bring into those discussions so that we can be much more front end focused and not MacGyvering our answers on the back end.
I think we probably have set some kind of a record for the use of the word MacGyvering in a conference. So we'll mark that down and move on to Erin for the next question.
Hi, everybody. Thank you so much for your presentations. I 100% feel your pain on the front lines trying to manage supply chains. One of the things that I think would be helpful is if you all could maybe speak just a moment to the pressures that your health systems are under in product selection, costs, the budget constraints that you're under, the reimbursement issues that can drive specific product selections in some cases as part of that supply chain issue. And yeah, thank you.
Aaron, I can talk about that. Having been in practice in hospital pharmacy as recently as 3 years ago, obviously, especially with the COVID pandemic and budget issues because of elective surgeries being temporarily cut off and other problems, we're acutely aware of cost issues. So yeah, with contracts, whether it's GPO or contracts that are negotiated on the side, the goal of the hospital is to save as much money as possible on a drug product. And Aaron, I know you're aware, but for others who aren't aware, when you go into an ordering system to pick a product, you generally have very limited information about the product. You have the manufacturer's name, you have the price, whether it's on your GPO contract or not. But there was some discussion this morning about the information on inspections, FDA inspections is available. Well, actually, it's not really that available. A lot of it's heavily redacted, and the average drug purchaser does not have the bandwidth to go through and read every 483 form or FDA warning letter. So really, there's no way to know the quality of the product. So you end up buying whatever is the most cost effective. And in this case, you have no measure of effectiveness. You just have cost. The reason why we're so budget conscious is because many of these drugs are not reimbursed, particularly by CMS. So if you look at what's reimbursable, most of the products we've talked about that have been shortage are generic injectables. I believe Dr. Schandemeyer mentioned that yesterday. These are products that go into routine care, whether it's saline bags or flushes of solution or even vincristine that we talked about. It's not an expensive medication. So there's no reimbursement for them. And so we do everything we can to save money on those products. And again, there's no insight into how quality and those economics are related as far as on the front lines in ordering drug.
And if I can provide one perspective, Aaron, to your question, and I certainly don't have the detailed answer to all of it, but at least for the pediatric perspectives in our dealings with multiple different hospital systems across the country and working with Children's Hospital Association, CHA. So there's been an interesting phenomenon over the past 9 months where certain, economic pressures, providing PPE, getting certain supply chains, if you're talking about a specific pediatric item, hard to get, one supplier, finding a backup supplier is a major challenge. Sometimes now you're going international. Sometimes you have no way to vet it, and you have no way to figure out, who's doing this. I have kind of appreciated every hospital and every hospital system for peds seems to have a different mechanism already internally vetted for their local regional area for how they deal with this. And it doesn't always work. And the truth is, the deepest pockets win. So the hospital systems who have thought about this and have complex systems with lots of money and resources, they've been weathering it okay. The others are having to barter and trade. That brings up this final interesting revelation that I didn't know until I started looking into this year. There's a forum out there for kids. Children's Hospital Association has a blog, a little I don't know, a forum for logistics managers to come on, type little notes to each other across the country and ask and share about problems. And whenever they need something, they go on, they type what they need. They find, oh, Cleveland found, extra supply of masks from DC, and DC just sent it over to Cleveland. None of us knew this was happening. The PEDS logistics guys are all just doing this behind the scenes.
What is that forum called, Chris?
For the kids, Children's Hospital Association host it, and it's a logistics managers forum.
Amazing. Okay, interesting. Right,
Aaron, I think you raise a really good point. I mean, the pain points right now continue to be the N95 respirators, continues to be isolation gowns. Nitrile gloves are going to be even more in demand because you had labor violations earlier over the summer months with the factories over there in Malaysia, and now they're going to be shuttering on a rolling basis the 28 factories, I believe, that exist in Malaysia, due to COVID infections. And so with these rolling closures, it's only going to create more of a problem for nitrile gloves. What I can tell you, ARM and the AHA, we have been acting as a clearinghouse for the healthcare supply chain professional in vetting the non-traditional sourcing channels. A lot of hospitals have been going to the non-traditional sourcing channels for PPE. And we've done a first level vetting of these vendors, and we've vetted probably over 1,000 and have approved 400, and we host those on our publicly available COVID resource site. We're also supporting a couple of industry repositories by providing the vendors we have approved so that we can build a more robust repository for supply chain professionals and other businesses, to be honest with you, because businesses now have to go out into the PPE marketplace to buy products they've never had to buy in the past. So these repositories provide a further level of vetting for these non-traditional channels. You talked about pricing. There's a Kaufman Hall report that was released this week that talked about hospitals and the operating margins that have fell almost 20% this year. So that's a huge concern. You've got PPE costs where an N95 mask typically costs 50, 60, 70 cents a mask, upwards of $10 per mask. So you've got these increased cost pressures on supplies. You have increased labor expenses where you're bringing in additional nursing staff, maybe some traveling nursing to help augment the existing staff to care for the patient load. So a lot of these pressures are what we're facing on a day-to-day basis. I can tell you, in addition to these vendor vetted repositories, I think you're seeing a bit of a shared economy concept start to take shape. The state of Massachusetts has just implemented a program. They've divided the state up into 5 different areas where they will share resources. If a hospital has a very high census, they will move some of those patients or some elective procedures perhaps to a different hospital. They'll share resources and supplies, maybe even staff. And so I think that you're seeing this, we're all in this together mindset, just strengthen as COVID continues, and you're seeing more of these shared economy resources. The AHA has developed the dynamic ventilator reserve, where we've got over 2,500 to around 3,000 ventilators in a virtual inventory that we can move from low use areas to high need areas. And there's other third-party platforms out there that are doing the same thing. So while you have these cost pressures, what's incredible to see is the resiliency and the creativity and, again, the coming together of the healthcare field to really tackle this together. And I think that nobody does silos better than healthcare. And I think that the COVID has really helped us to tear down these silos and really come together and how do we help one another. So I'm encouraged by that. If there's anything I can take away from COVID, I'm definitely encouraged to see that happen in the healthcare field.
Great. Thanks, Mike. Louis, did you have a question?
Yeah, and I'm not going to mention a certain TV series from the mid-1980s, ABC. It was one of my favorites, but I'm not going to say the name. So I'm glad that the discussion has turned to devices, because I do want to ask all of our guests as frontline healthcare providers. The term drug shortage was part of all of our vocabularies long before pandemic. The term device shortage was not, at least to me, as familiar a one. Now, in the midst of COVID, we're used to the notion of, PPE shortages and ventilator shortages and test shortages. My question for you is, since we as a committee are looking not just at this pandemic, but at a broader category of risks, do you have views as practitioners whether there are certain parts of the device chain beyond these categories we're talking about now, that places where the supply chain of medical devices seems fragile, situations where you have confronted shortages of various categories of medical devices outside the pandemic context, just so that we can be aware of that phenomenon as well as the drug shortage phenomenon. Thank you.
Yes. So single manufacturer equipment pieces. So when you have a rare piece of equipment and there's only one manufacturer, it's at risk. So, and for peds, I can give you examples of things like a 8.5 French Cook dilator set. It's only made by one company. You can only get it at one place. There's no substitute. If you don't have it, you've got a problem. However, I would also add something that I think Ryan was talking about that I think is very important, that's getting to what you're asking, Louis. And this is the breadth and flexibility of each of those pieces of equipment. So if you're talking about a ventilator, you need to talk about a ventilator that has full capabilities that can do, low tidal volumes. Otherwise, you really don't have a ventilator. And not all ventilators and manufacturers are the same.
Yeah, in fact, one of the challenges with the current SNS ventilator setup and again, it's wonderful that so many manufacturers stepped up to provide these new devices, but there are items such as the consumables that go with a ventilator. Ventilator is a durable piece of goods, but it has a number of consumables to go with it, filters, tubing and such. Those are not compatible between manufacturers in many, if not most cases, and certainly with a number of the new products. And obviously the operation, to get back to the staff side of things, the operation of a ventilator requires a certain degree of expertise on that model. It's not like I get out of a Toyota and I climb into a Ford and I can operate them pretty easily. There are differences in the maintenance and the troubleshooting and such that can be challenging in an emergency. Not that respiratory therapists and critical care folks can't learn those things, but when you have to learn 12, 15 different models, that slows you down at a time when you really can't afford to be slowed down. I would say one thing about, sir, you'd asked a question in a non-pandemic context. I'm unaware of what those words mean, so I'm going to talk about it in a pandemic context. But things like PPE, one of the challenges we have, and this is an outgrowth on some level, if we go back far enough to the HIV pandemic, that we made a move starting in the mid-1980s, and I say we, and I was in middle school then, shifted to largely disposable medical equipment, right, for reasons of staff safety and infection control. Those were done for good reasons, and I think on some level will need to continue to be done. But I think one thing that we can reappraise as we think about ways to build resiliency into our systems is looking again at reusable equipment, right? So I know that NIOSH, for example, is studying the use of elastomeric N95, a reusable device that is not as susceptible to a run on equipment and manufacturing shortages. And there are infrastructure issues that go with that. For example, how do we then sanitize and disinfect those devices? In my own hospital, we've been using more reusable gowns, reusable operating gowns in our intensive care unit for the care of COVID patients, and using a dedicated part of, but essentially our regular hospital laundry to manage those, because that can be done safely with proper training of our staff, to reduce the use of consumable single-use goods. And as a more rational and safe approach than having me have a row of bags of N95s that I rotate through once a week. That's not as much of an issue now as it was early in the pandemic, but that was once upon a time. So, not just focusing on the production of more N95s, but finding, is there another way to do it that won't leave us caught with, to coin a new phrase, our pants down next time?
One area. Oh, sorry. Go ahead.
Oh, please go ahead, Suzanne.
This is just a quick comment, and this might sound, I guess, somewhat pedestrian compared to supplies and devices used in facilities. But I think one thing that's been just interesting to watch in my disease community and in one similar to it is the impact of the shortage on just consumer products, cleaning supplies, alcohol. What started happening is, once you couldn't get Clorox wipes, people started using actual alcohol pads that people who self-inject need. The idea of disinfecting and keeping your home or wherever you need to go, if you must go out, sanitary, isn't new to people with reduced immune systems. We always do this. And so it's really been interesting to watch how people adapt. And it makes me wonder, are people able to use truly sort of aseptic practices at home when they're self-injecting or doing home dialysis or whatever they may need to be doing, because you just cannot get some of the supplies you used to be able to get. So it's more of a at-home functionality, but it still matters a lot to people who are severely immune compromised.
Point taken.
I had one more thought, and Louis, your question is I think so important, and if I can add, so, and this is echoing some of what others have said. So the Craig Kennedy, I think, said in the last session, thinking about this in terms of contingency or continuous improvement models and creating master lists, which potentially sublists, is kind of important. And the reason I say that, related to your question, is I don't think every hospital or every scenario needs everything on that list. And I think that has to be recognized up front of what is the purpose of your list and for what scenario and what hospital and what tent. And when you answer that question, then you have to ask, what is the right PAR level? How many of pediatric things do you really need, as an example? And you got to answer these few questions to get at which items are at risk.
This is Sally. I want to add to that, because I think that's been kind of a learning as well. We had organizations who were struggling trying to understand what their burn rate was so they could adequately project what that PAR level needed to be. And I think that's really important in terms of transparency, because I think there's been perceptions in a variety of different settings that there's hoarding going on. And so people don't have access to what they need just because somebody's got it locked behind a door that they can't get into. And that just adds to the frustration of those on the front line.
I think the hoarding is a really important point, and I know this group had kind of hinted around coordinated efforts to battle these shortages. But if you have too much coordination, everyone's reaching for that second line product at the same time. Not to say that the coordination is not a bad thing, but I think the standards of how to respond to a shortage are more important than we're going to use this as the next therapeutic option. And I'm not sure what we were referring to earlier, but I mentioned, and not to be self-serving, but our guidelines on managing drug shortages is very specific about identifying your product on hand, consolidating inventory if needed, understanding how you're using the product, where your usage is, that strategy can be standardized across every shortage, whether it's drug or device. But if there's a sort of a declaration that, okay, we're out of, what was the example earlier, cisatracurium, and we're all going to start using rocuronium, well, recognizing that not just in the drugs, but also in the devices, they're making enough units to meet market demand. There's no incentive to produce more than that. There's no incentive to have excess capacity. So if everyone stops using product A and switches to product B, whether it's another type of mask or whether it's another neuromuscular blocker, that market's not built to handle that additional volume. So that amount of resiliency is also important, and that's why I hesitate. We talk about stockpiling, but that's exactly the response. As soon as there's a hint of a shortage, institutions start buying up that product, and they start looking at what product selection B and C might be, and evaluating supplies of those products too.
One of the things I'd like to add to this conversation that we haven't really talked about is the need for education. I think that post-pandemic, there's a strong need for education. We need to, right now during this crisis, we've got decontamination of N95s, which hasn't been largely embraced. There's a lot of concerns around how many times a mask can be decontaminated. And to be honest with you, during the midst of a pandemic is not the time to educate. But casting an eye towards a post-COVID environment, I think that education is going to be critical. We need to identify the science behind it and the data and share that with our physician and clinical partners on decontamination and reuse of some of these products. We also need to identify in what scenarios products should be used. An N95 should be used in this instance. Surgical masks are acceptable in all the other instances. So I think that that's a key component here that that really needs to be considered as we move ahead.
Okay, thanks everybody. That was a good exchange. Mashid, did you have something you wanted to raise?
Yeah, this is a question for Mike. So Mike, you mentioned resource sharing in the form of even staff and other resources. And how much of the solution do you think to the supply chain issue is in kind of resource sharing or risk pooling? And if it is a big part, what would incentivize hospitals who may be competitors at baseline to play nice together and share resources?
Yeah, that's a great question. I think that's, to me, it'll be interesting to see how long that goodwill and that collaboration and shared economy mindset continues post-COVID. Again, I think right now in the midst of it, it's this mindset of we're all in this together and everybody's locking arms and trying to get through this. So I think that's going to be a big question, a big hurdle to clear to see how competitors continue to collaborate. I think that, we need to look beyond our current approach. It's clear that it's no longer going to work. We cannot continue to have an inflexible supply chain. So we need to look at how do we augment that? Is it through shared economies? Is it through the use of technology? Is it through what I'll call fattening the supply chain all the way across the continuum? Is it regional coalitions of surge inventory management? I think we've realized the strategic national stockpile, some of the Achilles heel within the management of that. So I wish I had a better answer for you. I think that it's working now. Again, the big question is how long will that continue? I think my greatest fear is that we get past COVID, we all take a collective sigh, and we all go back to the swim lanes we've been in for the last couple of decades, where we look at price only and we keep driving down the price, which is one of the key variables that has led to fewer players in some of these product category marketplaces. And of course, moving manufacturing to the lowest labor markets globally. So how do we combat that nature to go back into that swim lane or step into that kind of comfortable groove that we've been in for such a long time. I don't think I answered your question. I think it's going to be more kind of a wait and see. Unfortunately, the optimistic side of me says that we'll learn, we'll hardwire, and we'll take those necessary steps. But I've also seen a history of previous pandemics that these very same things we're talking about today have been documented, and there's reports, and here's what we need to do moving forward, and we just haven't done that. So how do we not have that happen this time?
Thank you.
Mm-hmm.
It's well said, Mike.
Institutional inertia is very difficult to overcome, Mike. And hospitals are big time institutions.
Yeah, we just can't overcome that culture. That's our biggest hurdle, I think, that we have to clear. You're absolutely right, Craig. Well said.
Well, can I ask a question from a supply chain guy to those of you who are frontline providers? If I had come to you 2 years ago and said a global pandemic is coming, it's going to be an infectious disease incident. I don't know what the virus, the pathogen is going to be, but it's going to be something like that. Tell me what you need from your supply chain to be prepared. If you had given me a list 2 years ago, what percentage of your needs would have been on that list, and what percentage would not because you were surprised by them? And I ask this because obviously the way that one prepares for a known risk versus an unknown risk are different. Is it mostly you would have told me most of the things that were short in this crisis, or not? Chris,
No.
you're shaking your head no.
I'm so sorry.
No, it's okay. That's
you know
important.
what? That's the truth.
I'm not trying to get an answer. I'm just trying to find out what you would say.
And let me tell you where my shaking my head is coming from. So our group began this discussion pre-COVID. So we started talking about this in November, December of 2019, looking at the whole system for pediatric specific issues. And from our perspective back then, it was a mess we didn't understand. And the best that we had was to look back at H1N1 and SARS. And yes, we had specific lessons learned from those previous examples. Now that we've been through a year of this, I will tell you the things that I looked at, for H1N1 and SARS was great lessons learned, does not apply to about half of what we have experienced over the past 9 months.
Really? Wow.
Not the same.
Okay.
Yeah. I mean, I think the part of the challenge with H1N1 and SARS was obviously the spread of H1N1 is comparable, but obviously the mortality and the burden on the health system is not. And obviously, and also H1N1 didn't last as long. I mean, H1N1 continues to circulate. It's just regular seasonal influenza now. And we had a vaccine available relatively rapidly, and it's, conventional. And SARS, of course, we were fortunate that was a geographically confined entity, right? With outside of Hong Kong, other sites in Eastern Asia, and Toronto did not impact the rest of us greatly. And I know people have referred to Ebola as a pandemic. I would say 7 cases of Ebola in the United States is not a pandemic, right? It was a local epidemic that had impacts on the rest of the world, but in terms of its impact on the health system, it was nowhere near as great for us in Europe, in North America, and most of Asia. What would I have ordered? I would have ordered more PPE, right? I would have ordered more vent circuits. Speaking with colleagues in New York at the height of the pandemic, everyone was worried about running out of ventilators. But the tragedy is that, reporting them at the height of the surge, mortality was so great that patients died before they ran out of vents. And that's a horrible, the worst possible way to avoid that problem. Yeah. I think one of the tragedies is obviously we've had reasonably good pandemic planning in the US for a number of years. And going back to the George W. Bush administration, and a little more than a year and a half ago, WHO, thought that we were a very well-prepared country for a pandemic. in some ways we remain so. I mean, society has not collapsed. It's not the Lord of the Flies outside of my house. But at the same time, one thing we do need to look at, and as my colleagues have said, going forward, is figuring out some way to coordinate. And that's on every level. That's on every level. That's health systems within the city. That is, patient and clinician groups, as Susan said. It is different levels of the government, right? Within DOD, we communicate pretty well with one another. I don't know how well we communicate with HHS. I think pretty well, but that doesn't mean that there aren't areas for us to improve with that. Actually, honestly, Operation Warp Speed has been a pretty good example on the vaccine development side of ways that HHS and DOD and other organizations have, and private and academic organizations have learned to do this pretty well. The CoVPN is run by Fred Hutch at the University of Washington, but works with HHS and the military and NIAID. And so, there are successful models, but, it is our nature to forget. And, you think about the cultural impact of the 1918 influenza pandemic. If you think about it, it doesn't exist. There are no movies about the 1918 Spanish influenza. There are no songs about it. We don't remember. And we have to avoid repeating that mistake.
Well,
go ahead,
really,
Go ahead.
It's a really interesting question. And I mentioned that summit we hosted in 2018, and we tried to look ahead at these scenarios. And would we have predicted all of this? No. I think we foresaw some of it. We tried to look ahead at the time. There was a concern with the trade war with China. There were hurricanes each year that seemed to intensify. And so we were looking at a smaller scale. And unfortunately, COVID was all of the above. We heard earlier about passenger airplanes, transportation, borders closing between countries, plants being shut down because workers couldn't get in, parallel exports banned in Europe. In some ways we're fortunate that the way the pandemic hit New York, because of the difficulty in getting drugs, if that had happened nationwide, we would have been much worse off. And so as my colleague Dan Kistner mentioned, we worked out how to get the drug to where it was needed. And fortunately, as this third wave is kind of hitting everywhere across the country, the drug supply chain has responded in a way to make it that it's not a rate limiting step anymore. So there are a lot of things that we sort of hinted at, but not having a full understanding of what the impact of a pandemic of this scale would have. The other thing I think we did not consider were some of, we've had issues with consumables or disposables like syringes and needles in the past. Those device shortages are not necessarily foreign to us, but the PPE has an impact on pharmacy in a different way. We have frontline pharmacists in ICUs and in emergency departments that are side by side with physicians and with nurses and seeing patients. And so they need protecting, but we also have pharmacy clean rooms where sterile products are handled. And so that's us protecting the devices, whether it's needles, it's protecting the sterility of the drug. So we require PPE in a different way. We also use things that we take for granted, like sterile isopropyl alcohol, to keep surfaces disinfected in our clean rooms. And that's been problematic. Suze was talking about outpatient hand sanitizer, things like that. Alcohol and cleaning supplies are just as difficult to come by on the inpatient side in some instances. So yes, we would have predicted a little bit of this, but not having the full experience of what COVID has taught us, I think we would just have scratched the surface.
Well, if I may briefly just add here, I think if you look at past pandemics and you create a Venn diagram, there's going to be an area in the middle where it's a lot of the same supplies, right? It's the N95 respirators, it's PAPRs, it's coveralls, it's surgical mask, gloves, etc. Right? So I think that even though we all know that and we can build up inventory on that, to me, the fundamental question here is how do we address human behavior? As my colleague Ryan had mentioned, he had 7 U.S. cases of Ebola, yet there was upwards of 200 times the normal ordering pattern that took place. across the US, right? So how do you address this human behavior that creates empty shelves of toilet paper in the grocery stores, and that gets transferred here into a healthcare supply chain where there's this pandemic hoarding mentality that no matter how well we prepare, you'll have product in locations in the US that will never be used, that will never be tapped, while you've got other areas in the nation that are experiencing severe shortages. So I think that's a fundamental question that we need to figure out how to answer.
That's a great point, Mike. I mean, we tend to think about the supply chain engineering as opposed to the supply chain psychology, but there absolutely is psychology at play here.
Yeah.
So, yeah. Okay, I don't see anybody with the hands up, and we are actually past our time. So I want to thank our speakers here. This was a fantastic session. Thank you so much for your time and your insights. This has been a very valuable day for our committee. I mean, we've gone from the high level, global supply chain strategy down to the complexity of a 9-tier device supply chain, down to the delivery of the products for individual patient needs today. And the trick that we're faced with on this committee is to knit that together into some recommendations where we can focus on that big conceptual level and yet make things better at the level where you all live here. Because ultimately, this session is what it's about, right? If we don't make practice better at the level that you work at, then there isn't any value to what we've done. So I appreciate the reality check that you've given us and the insights, and we have a ton to chew on. So thank you. I hope you're open to questions. We may come back to you with some ideas to bounce off of you. If so, please do respond, because this is a big report. We've got great people, but it's a lot for us. So more heads are better. So thank you all. Stay safe and keep doing the great work you're doing.